My name is Aurora Archer. I am the CEO and co-founder of the Bellatrix Group. We are immensely delighted. I see several familiar names on the webinar, but welcome today to the second installation of our health and human connectedness series. We are beyond honored at the thought leaders that are joining us today. So without further ado, I'd like to also introduce our co-host, Ms. Pamela.
Hi, everyone. I'm Pamela Raitt. I am a co-founder and the Chief Strategy Officer of Bellatrix Group. As Aurora mentioned, we're super happy that you chose to spend some of your Wednesday afternoon with us to talk about health and human connectedness. And today, as part two in our three-part series, we're going to talk about it specifically as it relates to designing connected solutions. I think for many of us, COVID was a wake-up call. For a lot of us, it was just a validation of things we already knew about how woefully disconnected our healthcare system is in many ways, how overburdened it is, how inequitable it is, and how unprepared it is to connect people, except for maybe the very privileged, to the services that they need to be healthy and well. And so we'll dive into that a little bit today. We're really thrilled to have four folks who are all leaders, all unbelievably smart and insightful, and who also bring perspectives from both in and outside of healthcare. I think Aurora and I have both worked in and outside of healthcare, and we continue to believe that healthcare desperately needs more inspiration and leadership from things that have happened in industries that have already allowed themselves to be disrupted to get to the needed change that all of us, I think, are craving. So I'd love to now turn it over to our four panelists to introduce themselves, and I'm going to start with Natalie Nixon.
Hi, everyone. Bellatrix, thanks so much for inviting me to join this really important conversation. My name is Natalie Nixon. I am a creativity strategist and the president of Figure 8 Thinking. I'm also the happy author of the Creativity Leap, so I've been bringing it along wherever I go, so that's why you see it in my frame. But I have a really loopy background in anthropology and fashion, and what I do in my practice is I advise leaders on how to apply creativity and foresight in order to get to more transformative business results. And in the design thinking, design strategy space, my work was in the area of service design, which I have seen a lot of application in the healthcare space. I'm really looking forward to the conversation. Thanks.
Thanks, Natalie.
Thank you.
Raja?
Hi, I'm Raja Shar. I'm the program director for product design at Drexel University, and my background is in industrial design. I did not recently publish a best-selling book that's on every single list, including Audible, but I'm really looking forward to reading Natalie's book. I just bought it on Audible, so I'm excited about that. Thanks for having me at this group. So my background, as I said, is industrial design. I have had a particular interest in healthcare for the past 8 years. Including teaching in biomedical engineering while I was teaching at Georgia Tech, and also continuing that path forward and focusing on women's health in my role at Drexel University. And I'm very excited about this particular discussion because I feel like there's a lot to unpack in terms of digital healthcare and healthcare overall, especially in light of the current crisis.
Yeah. Thank you, Raja.
Russ?
Sure. Hey, everybody. I'm Russ Stark. I'm CEO of Think Company, and we are a digital experience design and development company. You know, we've been around for about 13 years and have done work in all different industries by design. But certainly, a lot of the work that we've done has been in the healthcare space. So, hoping I can contribute to this conversation. And I myself have been a practicing designer for longer than a lot of longer than a lot of it had names. So now a lot of these disciplines have names. They didn't when I started.
I'm right there with you. Thanks, Russ. And Paolo, can you round us out?
Hello, everyone. Thanks for having me here, Aurora. It'll be a pleasure to have this conversation with everyone who's attending. Paolo Machado. I've had over 30 years of experience in the financial and healthcare services industry. I've spent the last 12 years working with startups and large companies to figure out how to basically integrate the emerging technologies and analytics to improve health and well-being, but also to improve how we deliver healthcare. A lot of this is focused on who we are as human beings and what healthcare means to us as individuals. My hypothesis over 25 years in healthcare is that healthcare is not a normal good. We have to start treating it as if it is not a normal good. So we need to apply all of the skills and knowledge and technologies and emerging analytics with that in mind, with that frame in mind.
Thank you.
Beautiful. Well, we couldn't be more honored to host all four of you. And I'm going to kick us off with our first question, which we will share with the entire panelists, is what do you think is the biggest challenges for healthcare to better connect people to the services that they need? And yeah, go ahead, Mr. Pablo.
Sure. I think one of the biggest challenges with healthcare in particular, different from a lot of other services and goods that we try to deliver, is just overcoming the trust issues. So these are not inconsequential when you think about decisions like, did I buy the right cup of coffee? Sure, there's FOMO, you could have maybe got a better latte, so to speak. It doesn't have really as much of an impact as, did I get the right cancer therapy? Am I seeing the right doctor? Did I choose the right health insurance? Health and well-being, financial and otherwise, are inextricably interwoven. These are huge choices and decisions, and we need to figure out how to create trust. And as we all know, across healthcare, that trust is lacking. Vast gaps. There's tons of analysis on this every year that shows there's massive gaps between who we trust in healthcare and how we have to partner with organizations and individuals we don't trust to deliver ideas to us around what are the best choices that we should be making as it relates to health and well-being. And because it is a for-profit industry, healthcare, we have an awful lot of stakeholders who are trying to drive us to make decisions that aren't best for us in the long run because they're going to make money off of the fact that you're making those choices. I'll pause there because we go on for an hour on this topic, but I'll just stop.
And Raja, I saw your hand up to, I don't know if you want to compliment something or share.
Well, yeah, no, I mean, I think adding to that, the ability to trust healthcare to providers and organizations to provide care, irrespective of issues of economic access, and also to be more equitable and ethical in their practices. I think that's still a huge hurdle as we're talking about the sort of financial motivation for a lot of healthcare companies as for-profit entities, whereas most people enter the field with the need to want to help all and like do no harm. And I think if we or especially if we think about sort of like the move to digital, when you're starting to digitize these healthcare experiences, you're really leaving out a lot of people who still fall in the cracks of not having access to reliable technology, reliable Wi-Fi. And so even things like making appointments and searching for doctors is all a digital thing. And we don't really have the digital access or digital literacy to be able to navigate that, in addition to being able to sort of understand what are the different healthcare related diagnoses and wellness related instruments and tools out there that are available. So I think we have to be careful about this shift to purely digital medical experiences as when we leave behind people that are falling beneath the cracks. And those are people that don't have access to these technologies, but also frequently older adults, and also thinking about accessibility within just from that human factor standpoint of, and also that language standpoint. So how accessible are you making this information?
Yeah.
I love the way that Paulo and Raja went straight to the human element that our current healthcare system consistently misses. And I would frame it, just to build on those 2 points, as healthcare, it would be awesome if healthcare systems redefined or extended what they consider data to be. And I shared a story in my book about a time when my father was dying of cancer, and I stepped outside of his room for a moment just to get a little relief from the heaviness of that chapter of our lives. And the nurses, of course, were amazing. Nurses are kind of like, along with farmers, are like the original hackers, and they always had like up to the moment insight about how he was doing. And I noticed a man in a white coat walking briskly down the hall, and he stopped right before my dad's room and asked a nurse a question. I ever heard him say Mr. Weathers, my dad's name, and she didn't know the answer. this was a different nurse, and then I introduced myself to him, and I said, well, you know, the other nurse on duty just explained to me, and I started to share a, you know, insight, and he interrupted me, and he said, I'll just wait until I get the charts. And it was a moment of feeling so dismissed, and I kind of reared up and said to him, well, you know, the story that the nurse had that I wanted to share, these also data. You know, stories are data too, and the limitation of only relying on the quant, and what the zoomed out data analytics can give us is a really big miss if we don't start incorporating a more integrative approach, in my opinion.
Yeah, Russ, I'd love to hear your thoughts, but I just want to share something, Natalie. You know, Aurora and I have spent quite a bit of time working in the maternal health space. Yeah. And one of the things that we've heard over and over again is that the incredible burden that electronic health records have put on nurses in particular, especially in the immediate postpartum space, is causing scenarios where, you know, one doctor told us it was maybe 2 minutes after birth, and I turned around and the nurse was looking at a computer screen. And, you know, this new mother was sitting there with a baby in her arms and probably a million questions. And also, to your point, Natalie, really just looking for that human connection. And maybe there's a story to tell, or maybe she's thinking about, who knows, right? Her own birth, the birth of her previous child, whatever. And it's just lost because the hospital at that point, especially in maternal care, becomes so transactional. You know, a clock starts ticking of a list of tasks that have to be done, you know, within 36 hours of discharging this mom to go home. And so I love your story because it's so true. And I love this notion of stories or data, because I do think our medical community has become so focused on capturing ones and zeros that they've kind of forgotten that one of the things that made medicine more personal was that it was personal, right? That stories were data. So I just want to add that. I love the way you said that, Natalie. And Russ, I'd love to hear, sorry to jump in and take your space, but I'd love to hear.
I'm happy to listen. I'm the commentary on the end, which is fine. Yeah, like for me, I really do. I think it's the human piece is where it's at, and I think a big part of how we're going to move things forward is about a real conscious and diligent effort to drive out ego and bias in solutioning, because it's there. It's a very human thing. I'm not even like calling anybody out on that. It's just that we all have to, as designers, you know, no matter where you're coming from, you have ego and you have bias, and it ends up in your solutions. And a great one is like, look what's happening right now with COVID. Like, hey, the way we're going to test requires you just pull up in your car and you do this. Well, what about people who don't have a car, right? But it's like, you know, I'm not saying it's that binary, but there are just silly things like that get put out because people don't even consider the people that don't have cars. And that's a real easy example, but that happens in many more insidious, deeply buried ways. And then it, you know, gets out there and it perpetuates, and it's not good. And so, you know, that's going to make things take longer, and it's going to make things be more expensive, and it's going to require difficult conversations, and everybody has to go into that being okay with that. And also can't expect, you know, the change tomorrow. But the thing that we can do today is stick the wrench in the system or knock the train off the track. Because if you don't do that, it will go where it always has gone, because that's what tracks do. And you know, we have to now call these things out and change the way we move forward, or there's no way that we can make this something that benefits everybody. It's going to just still benefit the few, as it has.
So Russ, you came in at the, oh, sorry, Paolo, go ahead.
Could I build on that real quick?
Yeah, no, go ahead.
A couple of other things to think about is there are a lot of large challenges in healthcare, right? Just the very nature of it. A couple of other things to throw out there, and I won't spend much time on them, is the difference between and acknowledging the difference between a need and a want of this type of consumer. What I want may be to go ahead and sit on the couch and eat chips and drink soda. What I need is not that. So this is not a normal consumer market where you just ask a person, what do you want? Because what they want is often the opposite of potentially what they need. That's also kind of interwoven with short-term versus long-term. That health and well-being, mental and physical, are long-term things. They're not things that you can just satisfy your thirst or satisfy your need for a pizza by pushing a button and it appears at your door in the moment. So short-term versus long-term is wrapped up with needs versus wants. And overall, the fact that it's all in the context of a healthcare delivery system that's for profit and not linked back to actual health and well-being in the long term as the goal, it's around short-term profits because that's what they're there for to do. They have shareholders, whether they be nonprofit or for-profit, doesn't really matter. They still have to make earnings. They have to hit milestones, et cetera. So those are some additional challenges that we have to, you can't just solve for one of these things. You have to think about how do you solve for the sweet spot on the Venn diagram to address all of these. Otherwise it falls apart. Because having addressed just one of these issues doesn't really solve for what you need in the long run. I'll shut up.
Yeah, and I think, I mean, this goes back to, Natalie's original assessment, which was, where a lot of our conversation's been focused on people, and I think that that's what healthcare should really be about. It should be about treating people, not diseases, right, is the expression that I think, you hear a lot. And if we were to focus on that, and we also focus on the people that are working in that system, then I think you have a better system overall. And I think it starts earlier, and then it gets back to that question of, are we talking about wellness or are we talking about disease management?
Right. Yeah, couldn't agree more with everything all of you said. And Russ, you brought up COVID, which of course it'd be difficult to have a conversation about the state of healthcare without talking about COVID. And I'm wondering, you talked about this notion of the wrench in the system. And I guess my question is, number one, does everyone believe that COVID is going to be that sort of watershed moment for us in the United States in particular that gets us to say, hey, there's just so, has it really lifted the veil enough? Regardless of whether you think it's going to make that seismic shift, I'm curious what you each are seeing in terms of momentum as it does relate to, because let's face it, some things have been forced to change because of COVID, whether they're temporary or long-term remains to be seen. But what are some of the things that you're seeing in terms of transformation based on whatever newfound awareness people have? Raja, yeah.
I mean, I think it's revealed a lot of inequities in the healthcare system as we look to see who COVID affects predominantly, which is communities of color, largely Black and Latinx communities all over the country. And then once we do that, then we can connect it with the civil rights movement that's ongoing and starting to see how that's part of this sort of systemic racism package, right? So that's one thing. And if we look at other areas in healthcare, maternal health being another one where this pops up a lot, we can see how these different socioeconomic and identity-based backgrounds intersect with their healthcare systems, and some people are gliding through and benefiting from the current system, and some people aren't. And then the other thing that I think is really important that it's doing is it's really connecting public health with the healthcare system. And I think largely public health practices have been focused on wellness, disease tracking, et cetera, but they've often been behind the scenes as this abstract thing. And now we can start to see these tangible actions that people do that are related to our public health practices as organizations, as schools, as individuals, as institutions, as retail environments, and how that is layered onto health and how that overburdens our healthcare systems when we don't have public health adequately managed. And then also the extreme price of healthcare. I think we can also see that with these $1 million bills that keep getting shared in social media circles for someone who goes in for COVID treatment. I don't think enough of that has been very transparent so people understand how much it actually costs to treat someone from a disease in the United States versus other places, and making those comparisons to talk about how we actually fund our system.
Yeah. Anyone else want to chime in on, yeah, Natalie?
I also see that the watershed moment that COVID-19 could be is not only around healthcare, but COVID-19 is such a wicked problem, and it is such a part of a larger system that one of the things that is happening is that because of the way COVID is playing out, or the way we have been dealing with it in our country, we are seeing now that housing is a public health issue, that transportation is a public health issue, education is a public health issue, so that you know, I used to be a professor, and I still have friends and colleagues in higher education. And so all the inequities are being pointed out when it's for a simple thing, simple air quotes thing as going onto Zoom for class. You know, a campus levels the playing field. Everyone kind of has access to the same resources, same domicile, and all of a sudden, how much peace and quiet do you have? How much privacy and space do different students have? You know, Russ pointed out, you know, the access points if you have a car, if you're on public transportation. So hopefully this will be a watershed moment, because not only for what it will expose about inequities in our healthcare system, but healthcare is so uniquely embedded in other stems and spokes in our lives. I'm optimistic that it will start to also shift things in those other areas of society, because it is inextricably linked, for, you know, in all those examples I just pointed out.
Go ahead, Paolo. Thank you, Natalie.
So in the healthcare circles, it's been a rising tide, right? The social determinants of health and well-being are inextricably interwoven for you as a whole being. The challenge is those parts of your life were never woven into the medical practice side, right? There's clinical care, which is the $3 trillion, 20% of GDP that's going to eat everything else in the long run, because it's a for-profit machine that's going to go ahead and do what it needs to do to treat you. And you being sick is good, because you make money off of sick people. You don't make money off of well people in that system. Whereas population health is literally on the other side of that. Their whole strategy is, how do we treat populations at large and drive precision well-being at a micro level across multiple stakeholders and coordinate that delivery of care so we can prevent people from getting ill. Of course, when they do, we want to have this awesome medical care system. When we are successful and starve off the medical care system, we want pop health to happen. We all want pop health to work, and the reality is it doesn't, because it's starved, because it's not profitable. And all of these components, financial well-being, transportation well-being, food deserts, I mean, these are all issues that have been around forever. I'm really glad, in a way, and that's why I'm a pragmatic optimist, there's a tremendous amount of opportunity to raise the tide for all. And all of these issues have been addressed somewhere. It just hasn't been distributed, because we haven't allocated the funds to make it happen equitably across the country. But there are solutions to the vast majority of these issues somewhere in the US, and if not US, elsewhere in the world. We just have chosen to not focus on addressing that as a priority, because it's not profitable in the short term to do that. And short-term quarterly earnings is what drives the $3 trillion.
Thank you, Paolo.
Russ, I think Russ was
Oh, I'm sorry.
Yeah, that's okay.
Oh yeah, I was just gonna say, so I mean, absolutely, you know, people having access to good Wi-Fi and technology and all of that is one piece that we need to solve for, right? And then, but to pull the lens out even a little bit more is like, you know, I think there's a lot of genies that have now, you know, been let out of the bottle that we're never going to get back in there, and I think ultimately that probably will be a good thing. But it's like, I know from experience that, you know, talking with clients or even us, I mean, we're a digital agency, and there are things that we never dreamed we would do remotely. And suddenly, well, we're going to do it remotely because we have to. And so we figured it out. And, you know, giant monolithic companies that never wanted to have people working from home. No, that could never work. There's no way that could work. Well, it's working now, isn't it? Because they had to figure it out. And, you know, what I like about that is that I think that's kind of a broader call overall, is I think in healthcare in particular, back to, you know, the whole idea of there's a lot of no that gets thrown around, and no, we can't do that because of legal or reg or whatever it is. Well, when it has to, you figure it out. And I think hopefully we're at enough of a groundswell and enough of a tipping point that there's enough voices saying enough is enough. This has to work. We have to figure this out. And you know, the legacy response of no, that'll never work is BS. We're past it. We can figure this out. Why don't we focus our energy here and make an actual difference? Because we've just proven that when you're forced, we all figure it out, and it's time.
But I would say that if we look at the accessibility community and disability community has been pushing for a lot of these changes for decades, right? and people have refused to do it. And so I would say that if we listen to the most vulnerable people that are out in the world that are demanding these changes, then we could be much more proactive as opposed to reactive, and like these light bulb moments of, oh, look at that, it's amazing that that actually worked out, right? It's something that if we put our creative energies around, that could solve a lot of issues before they even turn up, especially in their workplace scenario, but in our healthcare system as well.
I agree.
It benefits everybody. It benefits all of us.
And Rasha, I agree with you. I think that one of the biggest challenges to overcome is how do you address the temporal financial misalignment that exists? Because a lot of what we're talking about here is that we don't invest in the things that have long-term benefits: food equity, education, housing, financial well-being, all these things, physical fitness, etc. All the things that matter for the long haul are not profitable in the short term by and large. So we tend to focus on reacting to things that are bad because they are working in the short term. So it's a long-term, short-term financial discussion quite frequently that keeps us from making those investments.
Yeah, that sounds like a leadership issue to me.
It actually does make smart, intelligent business sense to deal with the least amongst us for the following reason. There's something in design called universal design. It's an area of design that focuses on designing for people who are differently able, who have physical limitations, right? And so I have extended, so short case story of universal design, the OXO kitchen products. So many of us have those nice spongy handled spatulas and knives and tongs and etc. Right? So the co-founder of Smart Design designed those utensils because his wife was struggling with horribly arthritic hands, right? So he wanted to ensure that she would have handles that would be super comfortable for her. Well, it turns out that when we design for the least amongst us, it's actually a superior design. All of us love those products. And so even when you look at something like microfinancing models that have come out of Bangladesh, you know, it's a design of a service for the least amongst us, right? It actually is better design. It actually is scalable, and it's something that is incredibly profitable. It just requires a paradigm shift. It requires a very different, it requires a different decision. It requires a different choice about what we will choose to fund. But the evidence and the research shows that designing for the least amongst us, if it's around healthcare, if it's around education, if it's around et cetera, the Tata car, right? That was a totally stripped, reverse engineered car. How many Western country automotive engineers bit off of that design? They're like, hang on, if you can basically figure out how to retrofit a scooter that a family of 5 has been driving. I used to live in Sri Lanka, so I'm quite aware of that scenario. And we could actually make it slightly higher quality, a little safer and affordable for the growing middle class. Well, how might we scale that to the United States, et cetera? So we can do this.
Absolutely beautiful. Thank you all for great answers. And I want to segue into the next question. But before I do, I just want to thank our audience members. Please, I see you all actively using the chat. We're going to get to some of those beautiful points that you're making. So thank you. Please continue to share your thoughts as we go through the Q&A portion right now with the panelists. Each of you has started to touch on this, because one of the key questions is, what are the elements that are needed? So, you know, universal design clearly is something that you've touched on, Natalie. You know, I have a personal bugaboo as it relates to, you know, the point that you also made, Russ, which was around leadership, because I would offer, and maybe one of you will add to this, I think it's about who we're valuing, right? I think it's choice, but it's also a predisposition of whose voice and experience we are valuing with regards to the solving of solving, creation, designing, imagining of services and solutions. But I'd love to ask you all, what are those elements that are missing so that we can evolve the digital solutions, services, non-digital solutions or services in the healthcare arena?
We need investors and venture capitalists that can invest in healthcare products that are for non-white men. That's what we need. Because I think that is where healthcare has failed, is our products have largely tried to serve the majority because of the economic buying power there. And we have tried to take those solutions and apply them to children, apply them to women, and to apply them to people of color. And we've seen time and again where even in algorithm development, there are biases that are inherent in some of those algorithms. And you can see that from anything from washing your hands with one of those, motion sensors at a gas station and the water doesn't come on. It's because the algorithm doesn't pick up on darker skin tones, and so it doesn't know to come on. So there are biases into these everyday products. And so when you are designing for and without the voice of people who fall out of the majority, then you're leaving out a huge part of our population, and those are the people who our healthcare systems continue to fail for. So as we're moving forward into the digital space, we have to make sure that those perspectives are included on the teams that are doing the design and not just thinking about who we're designing for.
Yeah, and Stephanie in the audience just raised a really good question that I wanted to build on Roger's excellent point. Newsflash, it's predicted that by 2043, the United States will be minority majority. So there is a very different purchasing parity that is emerging, right? And also, your markets are not just constrained to your nation state. This is a global marketplace. And the global market consists majority of Black and brown people. So we have to really shift, because again, it's just intelligent business. If people will no longer be moved by a moral imperative, which I, as an African American, my ancestors have been struggling for centuries to shift the mindset in that direction. So let's say, okay, we can't move the needle on a moral imperative. That's unfortunate, and that's like a huge, colossal understatement. It's just not intelligent business, and the purchasing power in our country is shifting. And to Raj's point, we need equity and representation on both sides of the equation in terms of who is doing the designing, as well as acknowledgement of for whom you're actually designing.
Yeah, I love that, Natalie. And I want to add on to something you said earlier too about data as well, because I think data is a part of this too. That, like, it's funny that I think another thing we need to fix in the healthcare realm is this idea of, like, it reminds me of like the old school priests, how like they were the only ones who could read the scriptures, and so they could control the population because they knew what was in there or no one else could read it. And it took the printing press to get it out there and get the data out to everybody. And suddenly it changed. And healthcare is still like that, right? I mean, like, healthcare is still like that, where it's like doctors are, and it's not anything against doctors or people in the admin part of the organization, whatever it is. They have the data that no one else has. And it's this weird thing, like we're all at their mercy. And the way that the data is controlled makes you feel that way. You can't even get your own records a lot of the times, or things aren't shared. And it's this weird monolithic keeping of data. And I think not only is that wrong, and if you want good outcomes, you should have everybody kind of connected with one another and talking with one another. But it's just like, it's unfair, and it doesn't make any sense. And I had another point I was going to make there too, and I lost it. But I feel like, I know what I was going to say, is that we probably all have also experienced, you're talking to somebody who's an expert, and then you're like, really? Because I kind of didn't think, and you realize that we're all humans. It's humans doing jobs, and no one is infallible. And just because you have a degree appended to your name doesn't mean that you're not going to make a mistake, and that the patient, his or herself, might say, actually, that doesn't seem like what's happening with me. And then, oh, gee, yeah, maybe we shouldn't do that, right? Maybe we should all do this together, and it's not just this top-down approach that is perpetuated in the systems, in the sharing of data or the not sharing of data, in the way people are treated or not treated, in the way people are even, you know, like your conversation before now, like what, like you're not good enough for me to share what's in the chart with you. I'm just going to wait. It's broken. It's like socially broken.
Yeah, so to build on that, the lack of transparency is just a hallmark of healthcare, has been for a long time. It's going to be taking a lot of leadership with, frankly, a lot of courage. It's going to bring new models forward. And all of that's great. And they still have to be making, because they are businesses, have to make revenue and profit targets to make that all happen. So this all sounds wonderful at a macro level. But in the normal investment community is not going to be a big chunk of the solution here, because they're looking for quick ROIs, unicorns, fast, massive growth in companies, which frankly drives the prices up, which we're already too expensive as a country as it is to deliver healthcare. I really firmly believe you're looking at something that has to come more from the public sector. Where
I mean, I guess that's the point I'm making. The public has been asking for a lot of these solutions, and people have just ignored them because the people with the money don't represent the folks who are asking for it. I'll use breast pumps as an example. People were trying to and calling for and working to put wearable breast pumps on the market for decades before we actually had successful product solutions on the market for that, because there was not the investment in women's health. And so when companies were founded by women, for women who had lived through that, and women are 50% of the world's population, right? So you're talking about half of the world, effectively a large percentage of those people. Yeah, well, a large percentage, 51%. Will go forward and produce children, and then a large percent of those people will breastfeed those folks. So we suddenly had, with Obamacare, the funding through insurance reimbursements. You could get receipts. I mean, you could turn in your receipts and get breast pumps paid for. And it wasn't until people made cases for that people started to realize they could make money off of it. Whereas the breast pump market is huge and terrible, and it does not serve its population well. We have been complaining about it since they came out on the market. The user experience, the product design, the sanitation, the mechanics of it have often failed and been inferior. And we've had to put up with it because it was designed by men for companies that were led by men, and they ignored the needs of a huge consumer market, which, by the way, breast pumps cost like $300, and I paid cash for them. So if I'm going to pay that, you don't want my $300? Like, give me a better product. So I understand what you're saying, Paolo, in terms of, you know, the economic situation needs to be considered along with sort of like this macro view of like inclusive voices. But I think if you actually listen to who has those voices, we have money. People just don't want it. And they're not listening to anyone who's telling us because they literally we're invisible to them. And I think that invisibility, or those blinders that is on the investment community, especially as it relates to healthcare, is holding us back as much as a lack of leadership.
Yeah, and I can just say one thing, because I think this is one of the challenges that when I hear people say, well, when we hear diversity or we hear inclusive thinking, we automatically go to poor, brown, and black. And I think that, again, there's sort of this connection that we make in our minds that I think is false. And I think it continues to perpetuate the choices, the value, the investments, versus looking at it much differently than that. You know, yes, there's a swath of brown and black humans that are disproportionately disadvantaged, but there are also folks that are sitting in those populations that are having monetary impact that they can make in a purchasing and empowerment model that, just to your point, Roger, just completely gets ignored. Because we bucket it over here and just sort of say there's nothing there, so we're just going to solve for over here. White male, cisgender, has $100,000, and everything in between there gets completely lost. So I think, again, it just goes back to in my view, there's just such a tremendous opportunity for mind shift, and also leadership shift, and who gets invited to the table to participate in the conversation of leadership, of creation, and imagination.
Yeah, and I think, you know, Paolo, to your point, I mean, people are going to follow the money, right?
Yes.
But what's good about that is that if you have the right people if you have the right people doing the design work, bringing in the right people from the community and a representative group of people from the community to help design those products, you know, we know that, you know, and Natalie, you probably would know this because I know you know the academic side better than me, but you know, there's like studies how over time, you know, people used to feel like things that were well designed were not for them, right? And that over time, good design has become more democratized and people are able to make those choices, and they do. So when things are smartly designed and intuitively designed and everybody is choosing that, you know, even the people who are just, you know, miserly at the top with their little pocketbook, they're gonna sit up and take notice. They are going to. So, you know, I mean, there's a way, I think, maybe to bend the fiscal arm of this towards the arc of good by just doing the good design up front, because people choose it, you know.
Mm-hmm.
Yep. So I want to move us on to our next question. And I'm actually, as a way into that, I'm going to go back to something you were talking about, Russ, which is the notion of data. Because I do think one of the things that we see, and I'm sure all of you have seen this too, is, you know, in practically every other industry, data is leveraged for my benefit as a consumer, right? I have a personalized experience when I go to the bank. You know, Starbucks knows everything about me, Amazon, Nordstrom. I go buy something and Amazon will tell me 3 other things I might like. I go to Target, you know, it's on and on and on. In every other industry, really, there's a real value exchange for me saying, yep, I'll turn on location services. I'll turn on, you know, this, that, and the other thing, because I know that these companies that I interact with are going to give me something in return that's of value to me, that makes my experience more delightful, that reduces friction, that introduces me to other products and services, and that I feel somehow makes my life better. And for some reason, you know, healthcare is one of these industries that has not done that. And in addition, you know, based on what you were saying, Raja, you know, it has not really bent to consumer demand, right? And obviously, you know, healthcare is a much more complicated system. It's not a system where there's a direct-to-consumer model. There are providers, there are payers, and then there's employers in some cases. If I have employer-provided, you know, health coverage, there's a lot of people in the ecosystem that come between me as a consumer and my ability to get what I want. So unlike, you know, examples like retail where consumers said, no, I want things faster, and it was very easy for e-commerce to come in, it's a little more complicated when it comes to healthcare. So I'm wondering, you know, what do you think and see as it relates to operationalizing some of this change in health? What does it take? I mean, does it literally take blowing up the system, you know, and going to a single payer model? Or are there ways that maybe you're already seeing? I know there's a lot of new, you know, interesting models coming into the healthcare system, even in terms of alternative insurers. But I'd just love to hear each of you kind of reflect on, you know, it's not going to be driven by consumers entirely the way it was in other industries. So how do we get the same level of personalization and so on and so forth that we get from other industries in health? Paolo, yeah, go ahead.
Yeah, I think we're seeing it happening now. We're living through it. Most of us do not have access to the companies that are emerging and doing exactly what you're talking about. So not everyone is experiencing it, but the people who are using companies that are on the leading edge of leveraging information and insight about you to deliver an awesome consumer experience exist. They're going IPO, they're scoring big money to move on to the next level, they're selling to employers, insurers are making inroads in this space. Healthcare, old health systems even are making inroads at this space. Clearly not the majority at this point in time. It depends on where you are, who your employer is, and if they contracted with these companies to deliver that care. I'll call out a specific example, Livongo. They went from a small company a number of years ago to worth multi-billion dollars. And they do it all based on tracking information at an N of 1 level and delivering actionable insight at the point of decision to their users. Are they available to everybody? No, because it's funded through somebody. So either your insurance company or your employer has to have that service, which is where we have to kind of reframe healthcare. Healthcare is not something that you have necessarily availability to everything that's available in the world. So even if you wanted to live longer, you could go and pay for it yourself. Most people aren't aware of it. 2, can't afford to pay for it themselves. So there's got to be this other stakeholder that gets convinced. So I'm very, again, a pragmatic optimist around the future. It will all come. It's going to take a lot longer than it has taken in other industries, because while you say that Amazon has done a great job of telling you everything you like, but it's within the Amazon world. I can guarantee you Amazon does not share my movie choices with Netflix. So when I see the queue for both, I know exactly what the right ones are, and they share my viewing across each other. They don't, because they want to keep you in their ecosystem. No different in healthcare. Everybody wants to keep you in their ecosystem so that they, have the lifetime value of a customer maximized for the investments they've made for you.
But I think just thinking about this idea of just data sharing and people having your data, I think there's still a lot of unknowns over the power of data. Yes, it can ease frictions within a system, especially when it's shared the way that we market it is being shared. Oh, let us know where you are so we can let you know there's a coupon there. But I still think there is a lot behind that black box where we don't know how that data will be used if it ends up in the wrong hands one day, right? Of the supervillain who's behind the curtain, who's going to use it to target, much more sinister activities as opposed to just like helping me make decisions. And then I also think there's a lot of fear or uncertainty or unknowns around how much free will we're giving up if we're allowing algorithms to help make decisions for us. Are we relinquishing some power as a consumer, as a person, or as an individual, where we become to rely on these systems? And I think you can see evidence of how maybe data is used in a way to control people. If you look at the social credit system that's used in China, which is actually used to score and track citizen behavior all over, from not only just their social media behavior, but it also tracks movements and dings your social credit score if you jaywalk across the street, right? So we're not just talking about data that's being used to help, we're talking about data that's being used to monitor, and then eventually data that's going to be used to incentivize or punish user behavior. So I think until there are protections in place and knowns in place, then I say that we have to be doing that along the way as we start to share more of this data across systems, and also make sure that we know who's in quote unquote control of it. Is it consumer in control of it, or is it a system that's controlling it? And then if that system is in control of it, it can take it away from me. And so now suddenly I don't have power over it. So I think we need to be thinking about who holds the power, who holds the data, how it's protected, and how it can potentially be used for good and for evil.
Totally concur, and that's where transparency is so critical. None of the other industries that we're talking about, retail for instance, they don't really tell you what they're doing with your data. They're monetizing that data. Healthcare clearly could cause a lot of harm, much more harm than making the wrong choice for what cup color you want. But I think end of the day, what's really critical is holistically looking at this and how do we make the information interoperable and fluid and transparent to consumers, knowing full well, by the way, that the majority of data I will dump on a consumer as it relates to the health and well-being won't be what they necessarily would understand or want to hear. So health literacy is a massive problem. And frankly, the average consumer would not know what to do with the vast majority of data that's hidden in some vault from them, and just dumping them on them is really, really a horrible idea. Well, they will make potentially very bad choices for themselves for their long-term health and well-being. And they're making those choices now, right? We spend way too much time on our phones, and we know that this is not good for us, yet there it is, right? That's the nefarious use of data to drive your behavior, right? This is a massive experiment on how to screw up people's mental health and well-being that we just can't seem to turn off and regulate. This is one of the worst drugs ever invented, right? Large studies have shown this causes damage, and yet it's all good. Just let it continue to exist amongst us. This is the biggest pandemic we could turn off tomorrow if we regulated it.
I think you hit on a really important word there, which is literacy. And I think that needs to also be part of the conversation. Maybe Russ has something to say. No, I think you guys are always thinking about how to make your different technologies and digital experiences more accessible and more legible.
We certainly are, and I'm kind of absorbing everything that you said and thinking it through. I don't know what I would add unless you have a specific question around that. But yeah, I'm just absorbing what you both said and what I think about that. I totally get the literacy thing, and I think, yeah, I mean, I think it's another tributary of the conversations that we're having every day about just like general accessibility, and I'm, and I mean that in both a physical and mental and financial, all the different ways that accessibility, creates hurdles for people, and trying to design things that are free of those, or provide the right assistance when you need it. Because I agree that like, any one of us, I mean, like, healthcare is fraught, right? But you could talk about it in terms of financial or anything, like, where if you had a lot of data and didn't know what it meant or what to do with it, and were making big decisions that could impact your life as a result, I don't think it's not like just by itself a good thing to put that in people's hands, because you could be assisting them in ruining their lives, or in ruining their health, or ruining the lives of their family, or whatever it is. So there's responsibility there in the creation of solutions, I think, to provide guardrails for people, like, for their ultimate health and well-being. I think, to some of the comments that were made in the chat too, I think it's about who is deciding the definition of health and well-being, and is it for everyone?
Mm-hmm. I want to jump back to what you were saying, Raja, about health literacy. We have worked with a partner over the years who is launching a female contraceptive. It's the first new hormonal female contraceptive to come to market in like 10 years, going back to everything we said about, the dearth of investment in women's reproductive health. And over the course of working with this partner, I've read a tremendous amount of research and literature and different studies that have been done about contraception and contraceptive access and contraceptive literacy, which is actually among the lowest forms of health literacy. And, many women in all demographics don't understand sort of the basics of hormonal contraception and how it works. And women of color in particular don't really understand. And this is a big part of how LARCs, which is long-acting reversible contraceptives like implants and IUDs, have been pushed on those communities, because women, quite frankly, don't really fully understand what they are. But there was a research study that was done, and I can't remember where it was done, and it actually might not have been in the United States, it might have been Australia, where they introduced contraceptive literacy to girls, from the age of like 14 or something. And then they tracked them over a 10-year period against a control group of girls who were not introduced to the same contraceptive literacy. And I'm sure you can imagine what the outcome was, right? There were fewer unintended pregnancies. There was greater rates of achievement of both high school and college degrees. And frankly, there was more economic, there was economic impact in their households and communities. So I do think this literacy issue is important. And then the second thing I'll layer on is, it's not actually just health literacy, it's actually financial transparency, right? Because the other piece that the healthcare industry, I believe, has kept so intentionally obfuscated is helping people actually understand what they're paying for. Is helping people actually understand why they're paying for things, and even helping people understand, what's something that I absolutely must pay for, and what's something where I have options or choices. So I think this literacy thing is tremendously important. And Paolo, you look like you're going to say something, but
yeah, everything you're saying, I think it goes back to the nature of healthcare being so different, because you have, in very few other markets, you have situation where you have a consumer who uses the product, the person who decides what you should be using, and who actually pays for it being 3 separate individuals.
And potentially 4, because your employer is paying for some of it too if you're not.
Yeah, I'm accounting the employer, whoever's actually writing the check.
Yeah.
And it's incredible. I mean, this phone, I chose this phone. I paid for it. I'm using it. And that's it. I mean, I'm the person. I'm all in one. Whereas now you have these vested interests who have very different perspectives. And we're oversimplifying it because it's a massive range. Just dumping information on people is a train wreck, because most people couldn't even process it. Just too many choices would create paralysis and just lack of comprehension, which is literacy. And then even if I could make a choice, which speaks to the issue around direct-to-consumer marketing, I think that's a train wreck. Because you're telling people who don't necessarily understand what's going on that they want something. They go to a doctor. The doctor says, "What are you talking about? That's completely not the right drug for you. Here's why." And now I've got to waste all this time talking you off the shelf because some persuasive marketer told you this sexy ad. Sorry, Aurora. The sexy ad for some drug looked really great. And now that person got the intended action, which is to get the conversation going. But that doctor knows that's not the right drug. So it creates tension in the system. And oh, by the way, even if the doctor wanted to write it, it's not covered by the PBM and your insurer and your employer. So then there's this whole like tension built up in the system, which happens on every decision. So until we get that alignment between those 3 stakeholders, or just frankly, someone said earlier, just blow it all up and remove money out of it and just a single payer. So there's no worry about who pays for it. There's only one payer and it's always aligned, so to speak. But right now there's this massive tension. There'll always be some between providers and consumers, because consumers will never know as much as their clinicians. That's why they go to 12 to 20 years of education, right? They're not going to know as much. They'll believe what they understand for them, what works, but the provider may know it's better for them in the long haul.
Yeah, I mean, I don't think we'll get into it. Oh, sorry. Go ahead, Natalie.
I'm finding these perspectives just fascinating. These perspectives on literacy and transparency. I come at this, obviously.
Oops, did she freeze on us?
I also am intimately aware of my own body and my own health, and I start with the assumption that other people are also intimately aware of and cognizant of the goings on of their bodies, even if they don't have a medical degree. There is, I don't assume that they're coming from a total tabula rasa. So what literacy does, which may be what's terrifying to healthcare, is that literacy sparks questions. Literacy sparks curiosity. In order to understand, let's just even have a conversation. Why is the marketer saying X and the physician is saying Y? And what is wrong with the consumers of healthcare being able to have conversations and ask questions if they are equipped with information? And by the way, there actually is an industry that we can hold parallel to this, and it's called education, where there is not a one-to-one direct relationship. And education is being blown up right now because of COVID-19. And there have already been so there's a couple of disruptions. On the demand side, the consumers of education, i.e. the generation of our daughter's generation, the Gen Zs, the Centennials, are questioning the learning model. They're questioning the ROI. They're questioning, why should there be a stage on stage? Why can I learn experientially? I've been predicting for quite some time we're going to see a return to some sort of an apprenticeship model. So we're already seeing another highly regulated industry where it's a complex system. All the attributes and descriptors you guys have been using about healthcare, it's in higher ed, it's in education, it's in all the different ways we can deliver education from elementary through primary, secondary school. So literacy, once again, we see in the education sector, has prompted questions and valid questions about the ways we have done things. So I find this fascinating about our assumptions, some people's assumptions about what's good for the patient, how much they should know, when really what it's leading to are different questions that maybe we don't have the answers to yet. But so what? It doesn't mean that the question shouldn't happen, the conversation shouldn't happen.
And can I follow up on that, Natalie? I think that that's something that we also need to talk about is who is heard when they ask those questions. And that's another issue that I think that we can maybe go back to women's health, in particular Black women's health, is terms of their relationship with their healthcare providers. And when they know their bodies and they go in with those questions are often ignored. And it all harkens back to systemic racism and bias, like in the healthcare industry. So I think that we really need to address that as well, because that's it's not even an elephant in the room. It's like all over the media, and yet it persists. And what you hear in reflections of doctors and other clinicians is that it's taught in the literature. Like that is what literally is part of the culture and the upbringing and the education that's baked into the system. And so there is not that opportunity to have these transparent conversations, even if people are empowered with literacy, even if those direct to consumer pamphlets somehow are triggering a thought that reminds them of an ailment they had 3 months ago they want to get checked up on. When they go to their healthcare providers, those conversations don't go anywhere. And I think that is literally killing people, right?
And by the way, the same, Russ used you referenced kind of a great metaphor, the Catholic Church in Europe, but that kind of the priesthood metaphor and parallels that we see in education, in healthcare, are, oh gosh, my point just slipped my head. Something you were just saying, Raja, about, this is what I was going to just say. The same kind of, the producer, the deliverer of the service knows best. We have the same problem in design. Design pedagogy is built around this assumption that the designer knows what's best for the end user, right? The designer, the end user doesn't really know what they need. The designer has to do all their observation and tinkering, and then ta-da, maybe they don't even do much observation. They just have this idea that they assume, without even that much user research, is best for the end user. So we have a model of relationship between producers and consumers that I think we have to re-examine, which is, it's starting to be re-examined, right? But it's kind of happening in so many sectors, including design.
I think at the end of the day, the bottom line is healthcare and well-being and human beings is a co-creation process between those who are consuming healthcare and being healthy and well from a day-to-day basis, and those who provide access to services to enable that success. A lot of it's on the consumers, and there's also a whole industry that can take your best self to the next level if we co-create it with them. And so there's clearly a need for consumers to have more health literacy and more role and more involvement. And it just has to be balanced with what is achievable as an individual. For instance, I love a car, want to drive one around. Do I need to know how the car is engineered? No. If I want to, could I go learn it? Sure. But I don't need to talk to the engineer, to the designer, to the builders of the car to have transportation occur. Same with an airplane. I don't need to know how a plane works, but I do have to have trust that some people are going to help me make transportation occur. A big chunk of it's up to me, but there's also a role for the other side, so to speak, to deliver that service.
Yeah, Natalie, I just wanted to second what you said wholeheartedly. That there's absolutely a vibe like in the design field of we know what's best for everybody. It's like this godlike controlling of things, and it's bad and it's dangerous. Yes, designers have skills and have expertise, and they should use those to look at actual objective data and do their absolute best to drive out their own ego and bias in doing so, to then make some sense out of it, to help figure out what the right solution is, and then go through processes of bringing in actual target audience representatives to test and all of that kind of stuff. But it is, I'm sure we've all experienced it, it's super pervasive. And the design industry is tough. There's a snarkiness there, and there's an attitude there, and it is very, very present. And it becomes the snake eating its own tail. So I just wanted to say, yes, I see it every day.
Thank you, Russ. So Pablo, were you wanting to say something?
I was just going to reinforce that happens in healthcare clearly. And I think it's wonderful to see that the next generation of clinicians who are being trained in the next generation of medical schools have very different attitudes. We have more than 50% of the people who are entering medical schools now are females.
Yes.
You're going to have a very different makeup of who the next generation of healthcare providers are. I know a lot of clinicians personally, and they get it. And they're in the process of changing how they engage and bring the consumer into the conversations that they're having. Is it everyone? No. And can you train everyone? No. There's some people who just are resistant. They've lived 40 years in this career and doing it a certain way, and they're going to retire that way. And that's okay. That's a transition for any system. You have to just wait some of them out. Some will transition effectively, and some will never know it because they'll only be brought up in the next generation. So the young residents that I talk to on a regular basis and coach, I'm very optimistic about what the future will hold.
So that was a beautiful segue, Paolo, for our next question, which is, I think a lot of what we continue to experience in the health industry is based on legacy thinking. It's based on models, perceptions, biases that need to be disrupted, need to be dismantled. And so, would love to hear your thoughts on how does the healthcare industry address the challenges with legacy talent so that it can actually propel innovation? And particularly, I'd love if there's any specifics, and you touched upon this from a provider perspective, in certain TAs, in certain therapeutic areas, there's already a shift that's happening around gender difference and, with more females entering, more women of color entering into specific realms. But how do you think, when you look at that health ecosystem, what is the opportunity of talent evolution, mindset shift in health? Because so much of it is hanging on and it's keeping us stagnant.
I'm really interested to hear the other panelists answer this question. But as we're starting to think about the mindset shift, I think holistic health, and I don't mean it from the standpoint of essential oils curing everything. I mean, thinking of the whole person and the whole system as part of our health and well-being. I think the conversation we've been having all along is the way to go. And I think we need to just get back to these general practitioners who actually are able to answer questions about maternal health, as opposed to always sending us down the road to another specialist, to another specialist, to another specialist, and start treating the whole person. And that means looking at mental health in addition to physical health, in addition to health history, in addition to nutrition, in addition to exercise. And I think if we can build a practice around holistic health as being the thing that keeps us healthy, and we allow the specialists to treat people that happen to be suffering through diseases. But I think that mind shift needs to happen, and it needs to come back there. And I think when you look at small town doctors who actually operate in this way, they cover it all. And I think the more you move into these urban areas where you have these experts and specialists who are paid way more than the market rate for your family practitioner for answering a question for 5 seconds, that we should enable and empower these generalists to be able to operate and treat everything here, and here.
Yeah.
Well said.
Anyone else?
One thing I would say is that I feel like what would be of benefit would be trying to move past the we can't mindset, which again, we're seeing it now. We talked about some examples of how that's happening with COVID, but from my experiences working with healthcare clients and stuff like that, I think we can't is just such a cop out. And first of all, we can't also perpetuates a lot of what we're talking about. We can't perpetuate systemic racism, perpetuates the same decision-making process, the top-down decision-making. And it is such a cop-out because it's not, I wish we could, but we can't. It's actually, all I have to do is say we can't, and then this goes away. Because people have no choice but to say, yeah, I guess not. And yeah, I guess not is not true. We're proving it now. Because if something changed in the marketplace or changed in the way that those organizations were set up, where suddenly it wasn't no, you can't. It's you have to. You'd figure it out, right? And so that whole we can't because of legal or reg or whatever it is, it's garbage. And it doesn't mean that doesn't make it easy. It's not that, I mean, you know, you've got HIPAA and all kinds of other things. Like, of course you have to adhere to that. But a good example of the we can't is either dropping that as a mic drop and then let's not talk about this anymore because we could never do that because the FDA won't let us or reg won't let us or whatever it is. Okay, there's that. But then there's also another way where people, like, even when they're well-meaning, might go through a long process of solutioning and then take it to legal or reg and like place it at the altar of those bodies and walk away and then come back and go, well, what did you think? And then they get no. And then they got to go take it away and try again, right? And it's this black box of like, okay, they said no. But the question we used to ask is why? Why did they say no? It's not enough. And we were always the vendor. It's like, don't tell me that I'm a vendor and I can't be in that meeting. You can't just tell me they said no, because we can't come up with another solution that way. And you're wasting tons of time and iteration and money and energy by trying to guess why they said no. So we got to the point where we got ourselves in those meetings and would hand markers to the people who were legal and reg. They're like, well, I'm not a designer. It's like, well, you are now, because I want to know how to fix this. I'm not going to go away and try again and then get on your calendar 3 weeks later and see if you now say yes. When like a lot of times it was like, well, actually, if you just said it this way, or, well, oh no, actually, you probably could do that if you just did this, but that's not the answer you get, right? It's monolithic, like light switches. Yes, no, come back in 3 weeks. Yes, no. And that's one example of many, many, many broken systems. And if we're going to move forward, we have to break these things. We got to be innovative. We got to stop being so siloed. Sorry, now I'm ranting.
Well, I just want to build on Russ's rant. I appreciate your rant, Russ. And one of the people I interviewed for the Creativity Leap was Michael Foreman, who's the CEO and founder of FS Investments. And something that I quoted from my conversation with him is, he said, as organizations get larger, they begin to solve for the tyranny of no instead of the fulcrum of yes. And that's just building on your point, Russ. In order to start saying yes, and heck, I don't know, that's a good question. Just admit ignorance. How about that? You don't have to be the expert all the time. That really starts to get into co-creation. I believe the way the question was framed, I think I heard you say, what are some of the I think I heard you ask, what are some of the mindset shifts that could happen? And I'm just going to pose some what if questions. What if you didn't accept people in med school who have no freaking work experience? Like, they're 21 years old, they have a degree, they passed the MCATs, they scored well in the MCATs. Okay, what if you really were trying to create physicians who were actually polymaths, who studied the humanities or studied carpentry, or were not just these siloed deaf thinkers. All evidence is pointing to a reality in the future of work and this fourth industrial revolution, which we are now in. The train has left the station. We need people who know how to ask a better friggin' question. We need people who are polymaths. We need people who are going to be able to draw in from a range of, who will be curious about the people seated in front of them. I also interviewed for the book my doctor, who's amazing. Her name is Dr. Daphne Goldberg. I am a privileged person who's able to afford a concierge doctor. And why did I do that? Because I suffered as a woman from uterine fibroid tumors. And I had horrific experiences. And I had amazing healthcare, incredible healthcare. And I had one experience too many where I felt like crap. It was already bad enough what I was going through in my body. And I was at a low point where I just needed someone to look me in the eye and talk to me as a woman. And because of that, I had to pay more money out of pocket, even though I had great health insurance, and I still choose to be healed and to live with this doctor, Daphne. I mean, I don't live with her, but you know, I'm saying live, you know, in like an energetic way. Daphne Goldberg, when I interviewed her for the Creativity Leap, and I wanted to understand, like, why is she the kind of physician that she is? She was part of an experimental medical school program at Penn, where it was this total integrative medicine thing. So you started by asking tons of questions to a patient. You didn't just look at the symptom that, you know, their lung is hurting. Then you zoom in, you take an X-ray or MRI of this part of their body. You ask them about their life. You ask them about, you know, what they've been up to this past month. You ask them about stressors. It's right. So what if we started to have a very different set of requirements for people who are charged with healing us, who aren't just good at conducting the robot that is 50 feet away from the person who's in the operating room, because that's happening, right? Surgeries are taking place with robots, and it's not person to person. So what if it was not an engineer who we want to be part of the healthcare system, but it's a person who's curious, who has life experience, who understands culture and literature and history and economics. That is my ask.
Yeah, I'm again very pragmatically optimistic that all of the things that you guys are saying are underway in healthcare. It is not something that's going to just get turned on and off like a light switch. You are seeing medical schools look for different types of mindsets of who is going to be a clinician. The over-specialization of healthcare has been underway for a long time, and that's an artifact of how the payment system works.
Yes.
You make more money for things that you do that are micro-focused. The fact that there is not, I mean, and a lot of these are being looked at and addressed at the very highest levels from a policy perspective to try to address them. You're not going to turn a $3 trillion Titanic by just sticking an oar in the water and just hoping that the boat turns. And so, yes, I think everyone is seeing this in healthcare that I talk to, whether or not they have the courage and leadership and financial resources to turn the boat. Different issue. These are all microcosms that you see. There are best-in-class solutions for everything we're talking about. And I see it in medical schools. Like, go look at the Dell Medical School down in Austin, Texas, right? Person running that is doing an amazing job creating the next generation of physicians who are diverse and interested and curious and more holistically interested. But what you're having to do is try to address what our need and our expectation, just like every other industry. Well, they changed travel in a few years. Why can't we just change healthcare in a few years? And the challenge is that you've got people who haven't been trained this way. They're not resourced to be something they're not able to deliver on because of the lack of the financials not being aligned. But I go back to design principles. What are we designing for, right? Health and well-being, like human thriving, personalized population health level stuff. And that's all great, but who owns that at a macro level, right? Somebody's got to lay down what you're designing for and get the right voices at the table, which is all stakeholders, because from a health and well-being perspective, there's no one who doesn't have skin in the game. So getting that to happen is going to be a long process, and you're going to see an awful lot of success occur. You're already seeing a lot of it. You just don't celebrate all of it nationally simultaneously. There's amazing things happening in places like Kaiser and Intermountain and Providence and UPM. I mean, you can go down these integrated delivery systems that are doing amazing things. It's just not available to 330 million people at the same time because it is a fractionated system. It's not a centrally structured system.
So Paolo, I think that's a great lead into our final question for all of our panelists, which is we'd love to hear, who do you think is doing it right? What have you seen? And actually, I'd also love to hear anything you've seen outside of healthcare that you think crack some of these same problems maybe that you think health could be inspired by. But who's doing it right? Who's doing it well? And who's starting to lead the charge? To your point, Paolo, maybe, you know, millions of people don't have access to it yet. And maybe there are some things about it that are imperfect, but who's starting to iterate in the right direction?
I'm going to say something truly controversial. Canada?
Yeah.
Honestly, it comes from the top. Like, it has to be like a policy, like what Pella said. You can't, it's not individual practitioners, because they come and they go, they only affect a small amount of people. Sure, you have great individual practitioners who are great. Like we've talked about Natalie's doctor. Sounds like a wonderful woman. I want her card. But she's one person, It has to be holistic. And if it's not covering everyone, then if it leaves anyone out, then they're not doing it right. And so I would say, look at the governments who have socialized medicine, because they've been able to figure out ways to centralize this through single payer systems that make healthcare affordable, that does not punish people for being unwell, that promotes wellness throughout. It's part of the culture, and that's where you see it being done right. But then you guys can go through and list all the different companies and Kaiser and blah, 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 that do integrated medicine that looks pretty good too. That's fine.
Great. Thanks, Raja.
Paolo, you were going to say something?
Don't think that's controversial at all. I was going to lead with a lot of the Scandinavian countries. And I think the reality is it's really culture that eats everything for lunch, right? And breakfast and dinner. And we don't have a culture of health and well-being and human thriving as individuals or as a population as a goal or objective at what I'll call the political level that reinforces that culture and puts it into policy that enables success to occur. And those countries you call out, Canada, Scandinavia, and a bunch of others, they do, right? Germany and other countries, they go down the path and say, this is a human right that everybody should have, and we're gonna give everyone access and equitable, and they find a way to drive innovation in the context of that still being the case. But they do agree that there is X amount of dollars we will spend on it, and we will coordinate care and deliver health and well-being based on the budget we have. You can't have infinite resources for health and well-being because there is no such thing as infinite resources. But we also need lots of other stuff too. We need education, we need housing, all these other variables, right? So you can't give it all to health and well-being, but there's not a balanced discussion in our country at a national level around human thriving as the objective of what a nation should provide its citizens. It's every person for themselves, go figure it out, whether that be at the state, city, or individual level. And frankly, goes back to your COVID question. I think COVID-19 catastrophe, ensuing financial pandemic, social unrest pandemic, and I'll add on climate disaster that's in the process of happening. We're just not paying attention. It's still going on. It's a perfect storm of all these things happening at once, and just shows that how we've structured isn't designed for human thriving in the context of any of that. I'll shut up.
Well, is that the iceberg that you're saying, that we can't turn the healthcare system around with an oar? But we know what happened with the Titanic when it ran into an iceberg. So is COVID-19 the iceberg that's going to turn everything around?
Time will tell, Roger.
Or are we just going to go down with the ship?
I won't go down with the ship. The question is, how much pain are we going to suffer? We could all learn lessons at different paces. You may learn after one time you bump your head on something. I may never learn it after 100 bumps. The question is, how many bumps in the head are we going to have? This issue of racial injustice has been going on and systemically there for hundreds of years. How many times have we had to bump our head and it's still there? Health injustice, that's been there for decades. And we've known it. Anybody who's in healthcare knows there's a 30-year lifespan difference in the same city, like Chicago, from youngest to oldest. Poorest neighborhoods, 60 years. Wealthiest neighborhoods, 90 years. That's within 5 miles of each other. Same resources available, right? It's a 5-mile distance. So that's been known, and policy just doesn't change based on that. It's just statistics. We need to make it personal and human-centered.
Well, and I would also offer is that, I keep reminding people, it took a pandemic. It took a pandemic and all of us being sequestered in our homes for us to pay attention that the health disparities, the health disparities are what they are and are not, are not the same for all of us. And it took a pandemic in the United States, at least for us to get to start, because we're not even done, but just to begin a conversation, a clearer and more honest conversation about race. And so it's like, okay, how many more pandemics do we want for us to wake up and start really examining our thinking, And I think one of the things we haven't talked about that I think is so imperative right now is people having the courage. Leadership at the top, in the middle, which is where most things get stuck, is in the middle, having the courage to shift the mindset, to do the thing that is uncomfortable, to do it because it's the right thing to do and not necessarily because it's going to pay off in a promotion or a title or you getting a brownie point or validation from someone in your hierarchical system.
Mm-hmm. Yeah. Natalie and Russ, do you want to wrap us up with some thoughts about who's doing it right?
Go ahead, Natalie.
I don't have a specific answer for that. I had heard that at Thomas Jefferson University, Steve Klasko was initiating an experiment where he was recruiting a cohort of new med students who were coming from Princeton University, who studied the humanities, who studied philosophy and history, etc. Who, I'm not even sure if they were required to take the MCAT. So I'm really curious to see how that experiment plays out. So I think that's something that's going in the right direction. I think that models like Oscar Health Insurance are trying to create a service delivery that is much more human-centered, a bit more simple and ease of use for people. I've always been appreciative of the work of the Mayo Clinic and the ways, they, at least for example, they have a service design team embedded in their healthcare delivery. I think just as in, again, I see a lot of parallels to education. Just as in education sector, you see lots of disruptors happening in kind of micro cells, micro units. I think that's what's happening. And I think COVID is going to really blow the roof off the mother, as we say. And it's going to have people start to question, like, why I've been put up with it like this? Like, why do I think this is okay? Just as those types of hard questions are being asked of education. Just as an education, there's a difference between education and learning. There's a difference between medicine and healing.
Yes.
And maybe this aware seismic shifts. I hope so. I really do.
Thank you.
Yeah, and I'll add to that. Yeah, same thing. I'm a huge fan of Jefferson and what's going on over there. And Banku's a good friend of mine, and like that guy's just like off the charts smart, and I love what he's focused on. And they've got their whole lab over there, and it's all great, But I think, I would just echo what was said before. I think if anybody's doing it right, it's because it's coming from the leadership, and the leadership is strong, and the leadership is then driving that culture. And I think maybe most importantly, if anyone's doing it right, it's people who are understanding that doing it right is not like a checkbox or a thing that you at one point check off and then you're good forever. You're doing it right if you recognize that this is ongoing, it is a journey, and you need to articulate those goals and what you're trying to achieve and understand that every day they will remain aspirational. And you might not ever get there. And you still have to get yourself out of bed and dust yourself off and just keep doing it, because we got a lot of work ahead of us. And I think when people recognize that and don't get discouraged or defensive or make assumptions or what have you, I think that's what we need. And I think those are the people who are doing it right. So that's right.
I just thought of one more example. I'm sorry. If anyone who wants to go to massdesigngroup.org, Mass Design, founders actually from Poughkeepsie, New York, but I think it's based out of Boston. But they have an entire collective and network of architects who have taken on a lot of redesign of hospitals. An example that I love of theirs is a hospital in Uganda, which is porous in that, who'd have thought that a hospital could have open air windows? Every room is designed so that Uganda is apparently an incredibly gorgeous country because of how hilly it is. It's just the country of hills. And so every hospital bed patient has a view of the outdoors. There's no view of a television monitor or walls, but it's a view of the outdoors, and it's fresh air coming through. So there are examples like that happening outside of the United States where people are experimenting with designing for health. Sorry, I just want to mention that. That's massdesigngroup.org.
And I also wanted to point out there's a lot of embedded nurse innovation networks that are within hospitals and medical schools and healthcare colleges that I think are really empowering the people who have probably the most human connection to patients and people in the world. And I think that is really transferring and divesting power to folks to actually innovate in the healthcare space from an expertise and also about the healthcare conditions and medical histories and all that stuff, but also an expertise in how people operate and behave.
Yeah, I have to add one more too on that. You want to talk about people who are treating people with humanity and working with people in the right kind of way. You write down on Broad Street Ministry. Look at what they're doing with their trauma-informed method of working for and serving our most vulnerable folks. It's a model that could be exponentially used in all different ways across all different organizations. It doesn't have to be just for the most vulnerable, but they're using it there. And what they're doing, I aspire to do. So
I dropped a bunch of names into the chat for people, and there are hundreds of others out there. They're in the process of transforming healthcare to be something that's much more holistic and human-centered design, not just for the consumers of health and well-being, which is everyone, but also those who are involved in providing that care, so that we also treat those people with the respect that they need as they're doing their job to do their best for us. Right now, they're fighting the system. I don't know any clinicians who are trying to cause harm. Any healthcare provider that's trying to cause harm in any way, shape, or form, the hearts are all in the right place. So the challenge is how do they exist in the system, and does the system enable them to be their best selves? And the answer is typically no.
And so with that, we are going to thank all of our panelists. What a robust, thoughtful, and insightful conversation. We'd love to thank everyone who has joined us this afternoon. No doubt there's much richness and gems that you received today. Thank you. Heartfelt thanks from both myself and Pamela. It's been an honor to host you and an honor to have this conversation.
Yeah, thanks everyone.
Thank you, Aurora.
Enjoy the rest of your day.
Thank you.
Thank you.